Hi, this is Dr. Alok Patel. I recently attended the Society for Hospital Medicine Conference 2019, and I had the opportunity to talk to doctors Melissa Madison and Ethan Kumbler about patient autonomy versus futile care. Check it out. So Dr. Kumbler, thank you for chatting with us.
Sure.
So tell me something. At the Society for Hospital Medicine, most of the talks that I go to, I'm seeing guidelines, I'm seeing protocols, and I'm seeing kind of like a stepwise way to manage problems. Does that apply to patient autonomy and futile care, or is there more to it?
Well, I think that this talk that Dr. Madison and I are doing illustrates some of the full range of what the Society of Hospital Medicine brings to its conference.
Okay.
Part of it is about how do we standardize, how do we add value, how do we reduce harm. But part of it is also the art in medicine. And when I think about how do frontline clinicians find balance between ethical principles, that's all about the art. There is not and will never be a guideline which answers how to handle challenging cases like the balance between futile care and the patient or family who might want that care to continue.
Right, which makes total sense to me because I feel like you can't standardize guidelines when you're dealing with varying people and cultural and spiritual beliefs. In your personal experience, do you find that you have to approach every one of these tough situations as like a new situation, or can you kind of apply previous protocols to each one?
That's a good question. For me, there are the underlying principles. These are the guidelines that we follow, but how they play out in an individual scenario, each patient is unique, each scenario is different. And so using a standard approach helps me to guide through the uniqueness and diversity that we find in the real world.
And now how are you guys defining futile care? So for me personally, I think about when my clinical judgment goes against what a patient or a family wants. Is that kind of where we're going with futile care?
Precisely it. And sometimes there's disagreements on the clinical team of what is futile and what isn't. You can imagine an oncologist who thinks that a patient should receive another round of chemotherapy, whereas the internal medicine attending says, this is it. Like, why are we doing yet another round of treatment?
Now, do you find on a day-to-day basis, when you bring this topic up in the hospital, which obviously happens all the time, are you finding that kind of debate or conversation goes between specialists or usually between yourself and the patient or the family or all the above?
Sure, I think it's all the above. It depends upon the scenario. The scenarios we're presenting two cases tomorrow. And one of the cases is really one that involved nursing, patient, family, the clinical team, the whole squad of people who were there to support the patient during their acute illness.
I think one kind of topic in this area that comes a lot in media news that the public knows about is when there's a conflict between family and maybe what a spouse wants. And so someone's saying like, no, we want do not intubate, do not resuscitate, and somebody else wants to constantly continue. Do you find that scenario happens a lot as well?
I think that at the end of the day, the clinicians always do their best and what's right by the patient. And it's not always black and white. Sometimes it can be a bit more of a gray area. And that can be hard to navigate.
Now, this isn't an easy topic. Like you have, obviously our viewers have all read news and, we get scared of stories around medical school where a patient has a wish that they want. They may not have the agency or the liberty to do that. You've got a family that then tries to coerce them and say, no, this is what we want. Then you have the physician and the subspecialties that want a different thing. Tough scenario. Do you feel like young providers are given the training to dive into this, or is this something that you're just going to have to learn on the job?
I think we're doing a better job than we used to at teaching people how to approach these complex conversations, these difficult conversations. But I think that some of this is experience.
Do you feel like we need more palliative or more ethics departments to kind of help mitigate this when you've got maybe a smaller hospital, a community hospital, or a place where people don't have your guys' experience? Are we doing good enough with the support?
We've come so far. I mean, if you look back 50 years ago at the paternalistic approach to medicine, we have come miles from where we started. But at the same time, I see huge value in palliative care consultation teams and in just colleagues where you can bounce some of these tough cases off of and hear how they would approach it.
What is the one message about patient autonomy and where we fit in that everyone should know?
Yeah, for me, it comes back to the patient. And so when you run into conflict between ethical principles, just like when you have a difficult conundrum and you're trying to make a difficult diagnosis and you're stumped, you go back to the bedside, redo the physical exam, redo the history. The same thing is true in conflict. When you are stumped, come back to the bedside and re-engage in the conversation.
Always back to the patient. Can you give me like the number one take-home message, if you had to just throw it out, about patient autonomy and what clinicians really need to start doing in 2019?
In 2019 with patient autonomy, well, we have to allow patients to partner with us as we navigate a very complicated world of what medical science can deliver. And we need to look to them as experts in what they want and what care is in keeping with their wishes. And we need to be the experts in the clinical space, navigating the waters for the patient and telling them what medical science can do for them in keeping with their wishes.
It's all about harmony.
Correct.
Dr. Madison, thank you so much
My
for talking
pleasure.
to us.